for the health work group in the Faculty of Health Sciences, and I'm especially delighted because I've known Dawn for some time because we worked together on a project about expertise in anaesthesia, and Dawn did nearly all the work on that project and was our chief ethnographer in operating theatres to help us understand expertise in anaesthesia. And this is just one of her many fabulous books about trying to understand what it is that anaesthetists do when they practice anaesthesia. So I commend that to you. You're allowed to look at but not borrow my copy because it's that precious. And Dawn is she's a senior lecturer at Lancaster Medical School. And she's currently managed to get some kind of deal where she's on sabbatical, which is why she's been allowed to come and play with us and talk to us. And she's a fantastic ethnographer. She is really interested in the cultures of healthcare work and understanding those with that kind of deep understanding that you get from doing ethnography and being there and seeing it. She sent the abstract for this talk when I was trying to twist her arm to come down here and be one of our distinguished lecturers. And me and Peter salivated on this talk, separately in separate offices. We thought we just went, yes, absolutely, we need to hear this. So I'm just going to grab my water and then I'm going to sit down and enjoy what I know will be a fabulous lecture. Thank you all.
Thank you, Kathy. That's quite a build-up. I only hope that the content can match the abstract now. But the project that I worked with Kathy on was pivotal in changing the direction of my career path, actually. But the things that I'm interested in and we're slightly obsessed by probably stem from that, really. So I used to be a nurse prior to doing that project with Kathy, and I think perhaps stemming from that is my obsession with accountability. And so if I just explain where my kind of interest comes from before I start, I'd done some previous work on looking at the kind of models of practice embedded in codes of practice, you know, the models of decision making that codes of professional practice were kind of premised on. And you know, I argue that they were very individualised. They had this idea of autonomous action, and decisions were discrete moments of one individual's cognition, you know, and it was very sort of deterministic in that sense. And then I looked at my ethnographic data, and that, you know, the two things just didn't kind of reconcile. My ethnographic data sort of analysed from a science and technology studies and ethnomethodology perspective, and looked at the sort of dependencies of collaborative work and how one person's thoughts and actions are so kind of informed by their co-workers and the environment that they work in, and that, you know, it's difficult to sort of tease out these moments of individual cognition. So these kind of entanglements that the way that we practice are sort of, so I ended up arguing that these entanglements are erased from view in codes of professional practice. And so, given that I'd argued that, you know, accountability was constructed in a very individualised way, I was struck by all these healthcare scandals that kept emerging, that seemed to find the cause of these scandals healthcare, problematic organisational culture, and I didn't, you know, I thought, how does that happen? Because I didn't think accountability was kind of able to encompass this kind of collective, collaborative way of working very easily. So I wanted to look more into that, into the way that culture was being conceptualised, and how it was being remade, and what inquiries were doing to the kind of concept of accountability. So what I'm going to talk to you about today is how these issues play out in the Morecambe Bay investigation, which, you know, I'm from, I work at Lancaster University, so this has, you know, a lot of local interest for me. So I was really kind of keen to look at what was going on there in my own kind of healthcare trust. And I don't know whether you're familiar with it or not, but this was an inquiry that was chaired by Dr. Bill Kirkup and investigated the comparatively high rate of neonatal and maternal death at one of the hospitals in the trust in comparison to the other hospitals in the trust. So Furness General Hospital, there's 3 hospitals within the trust, and there's Royal Lancaster Infirmary and the Westmorland General Hospital, and then there's around the peninsula on the other side of the bay is Furness General Hospital, and it was Furness General Hospital where the maternity unit had significantly higher rates, almost 4 times as high rates of neonatal death and injury than at Lancaster. So the Kirkup report found that serious failures in clinical care were responsible for 16 neonatal deaths and 1 maternal death over a period of 9 years. So that's just to give you some background on that. And the other thing I should say just before I start is I'm really interested in your feedback on this, because this is something that I've written and I haven't presented anywhere yet, and I've written, it's a sole authored paper, and I've got no feedback whatsoever on how this goes. So I might be the only person in the world that thinks this is interesting, but as, you know, I'm grateful to see what your views are on this. So, although it was the repeated appearance of culture that piqued my interest, I began wondering why so many inquiries, and, you know, what's this doing to accountability? How is it reshaping accountability? Where's professional regulation in all of this? And this observation was made by the editor of the BMJ at a time where there was lots of different scandals being investigated by public inquiry. There was the incompetent practice of gynaecologist Rodney Ledward, heart surgery at Bristol, post-mortem practices, post-mortem retention practices at Alder Hay, as well as Harold Shipman, all ongoing at the same time. And this recourse to inquiries has continued, as you are well aware, with the Mid-Staffordshire Foundation Trust public inquiry and the Morecambe Bay investigation following in quick succession. So increasingly, it seems, inquiries are the response of choice to healthcare failures. But before I could look at how culture is being conceptualised in these inquiries, I felt I needed to understand more about the structure of an inquiry, what inquiries do, what kinds of evidence they look at, and how these processes can shape understandings of what went on or what went wrong, and how this shapes the kind of construct of accountability. So, inquiries in general then have a very strong legal framing. They're often chaired by a judge or a QC, in addition to the support of a legal team. And this kind of goes a long way, I feel, in establishing the independence and the credibility of the inquiry, the composition of the inquiry team. The chair is appointed by the Secretary of State for Health, and then the chair appoints a panel of experts to assist him or her. And in the case of the Morecambe Bay, Dr. Bill Kirkup is a medical doctor with a public health background, and he'd served on inquiry panels before, but not chaired one before, and he was assisted by, he appointed a professor of healthcare and law, and then all the others were had clinical leadership roles in obstetrics, midwifery and paediatrics. So this team have wide discretionary powers to define the scope of the problem, but it inevitably reflects their own kind of expertise, and there's a sort of recursive pattern that goes on there. And also it's been said that they tend to reflect the dominant paradigms of causation as well, and this is where I think the culture comes in, because certainly in medicine at least, human factors approaches to safety have completely kind of dominated the sort of ideas about safety in medicine. So there's a certain way in which human factors use culture, which is where I think it gets a way into understanding what's gone on there. So evidence takes the form of performance statistics, and these performance things like mortality statistics and morbidity statistics, hospital episode statistics. These aren't taken at face value. The inquiry panels have a statistical expert, and these numbers are subject to thorough statistical analysis. And in the case of the Morecambe Bay one, there was a series of statistical analyses conducted to make sure that the differential rates in injury and death were not a product of the particular cohort population around Barrow, and that was felt not to be the case. So there's also medical records reviews, coroner's reports, and at the heart of the inquiry is individual interviews. Lots of people are called for interview, and these interviews are transcribed and often made. There's a lot of attempt to conduct these transparently. So interviews and all the evidence are usually made available on an inquiry website. So the inquiry website often publishes interim and full-term reports, and in the reports themselves there's use of verbatim quotes by named individuals. And in the case of the Kirkup report, it wasn't a public inquiry, because it was felt that the requirement to have public hearings wouldn't be kind of conducive to the tact that needed to be with which the investigation needed to be conducted. But instead, Dr. Bill Kirkup had 4 face-to-face meetings with the families involved, and they were involved right the way throughout. They were kept informed and had lots of opportunity to raise questions and for them to review the evidence that was being collected. So just to say a bit more about this personal testimony then, you know, such public testimony makes for a particular kind of accountability. In its favour, it promotes transparency, it builds public confidence that the inquiry is being conducted conscientiously, and potentially allows for a sense of justice and redress. However, it also individualises accounts, delineating one person's role from another and drawing lines of responsibility between one person and another. And you know, the attribution of accounts to individuals can provoke already troubled working relationships, and the retribution of that whistleblowers can receive is well known. So it comes at a cost. It's an obvious point, I feel, but it's worth remembering that the panel have total editorial control over how the transcripts are utilised and what's included and what's excluded, and how those excerpts are contextualised. And I think, you know, as qualitative researchers, this is something that you've got a kind of deep appreciation of, but when you're reading the reports, they're so compelling, you can kind of lose sight of it for a while. So as I was reading through the report, I was having to remind myself to kind of look carefully at what quotes are being used and how they're being contextualised, and if indeed they're being contextualised, and had in my mind the quote from Marilyn Strathern about contextualisation is never a neutral activity, and it's not without its consequences. And that's something that I hope to show you throughout this talk. So going back to culture then, given that the structure of inquiries leans towards the individualisation of accounts, it's curious in some respects that it should continually, that culture should be such a kind of a dominant explanation. And the Francis report is, of course, the most obvious example of this. I'm sure you don't need me to remind you, but there's a culture of fear. This is a quote from the report. A culture of fear in which the staff didn't feel able to report concerns. A culture of secrecy in which the trust board shut itself off from what was happening and ignored its patients. And a culture of bullying, which prevented people from doing their jobs properly. So that was the kind of soundbite from the Francis report, but it was not the first time that culture had been found to be problematic. In the Bristol heart surgery scandal, there was the inquiry there found a club culture which positioned too much power in the hands of too few people. And then what I'll talk about now is how culture is treated in the Morecambe Bay investigation. But so in some respects it's surprising that culture should take prominence as an explanation, but in other respects it's not so surprising given what I'd said about the orthodoxy of human factors approaches and the way that culture gets used in human factors approaches. And indeed, probably over the last decade or so, it's become quite commonplace to find in discourses of safety in medicine and healthcare that culture it's often positioned as a cause of healthcare problems and a lever for cultural change, as a lever for health improvement. And this has spawned a growing number of cultural assessment tools that attempt to disaggregate culture into values and beliefs and then measure that along attitudinal scales. And I've tended to take a rather critical view of this, and I approached this Morecambe Bay investigation with that expectation in mind. I expected to see something of a reification of culture like this, as something that's kind of stable and acts on people, and it being conceptualised in their as their values. But that's not what I found. So I had to rethink how I was going to approach this. So instead of finding that reification of culture, I found something much more sensitive, actually, and something much more sophisticated, I suppose. And I found detailed discussions of these themes. And unlike the Francis report, the Kirkup report doesn't really talk about culture as a thing. It talks about detailed sets of substandard practices and repeated and consistent failures in knowledge and dysfunctional working relationships and so forth. So it's clear, though, that taken together, this is the way that culture was being conceptualised by the panel and in the Kirkup report, because when you get to the end of the report, that's when it starts talking about how difficult organisational culture is to change. So it's clear that they considered these as constituents of culture. So I want to give you a bit of a flavour now of the culture that they found. And this kind of takes priority. This is the first thing that hits you, really, when reading through the report. This is in the first proper kind of findings chapter. This emphasis on dysfunctional working relationships. So the obstetricians have poor working relations with the paediatricians, and the paediatricians do not have good relations with one another. They were described as a dysfunctional team. And the midwives, that was a bit more subtle, but the midwives sought to avoid involvement of the obstetricians in the care of their patients, and the obstetricians remained content to be waited to be called, and then sometimes dismissed again as no longer needed. And that the origin of this way of working rested with one or two influential midwives who pursued normal childbirth at any cost. And this deeply flawed approach became more widespread and embedded in the practice of the unit. And this, you just get reading the report, you get an overwhelming sense that there are these three groups of professionals that really could not work together in any effective way whatsoever, and that they just avoided interacting with one another. The report gives examples of how poor clinical knowledge was exacerbated by a reluctance to collaborate. So the obstetricians proceeded to deliver babies of high-risk mothers at the unit, remembering the kind of geographical location of it as being quite remote. So they proceeded to deliver babies of high-risk mothers against the advice of the paediatricians, and the paediatricians were also unwilling to collaborate, to transfer their babies, and they adopted so for when the babies that were born there, they adopted a wait-and-see approach, which missed the optimal time to transfer neonates and necessitated some very kind of difficult transfers of very sick babies. With the midwives and the obstetricians, the relationship is one of disengagement and, in fact, exclusion of the obstetricians by the midwives. The obstetricians are cast as complacent and content to be excluded, and the midwives are portrayed as being fiercely protective of their normal childbirth boundaries. The report documents how the midwives took exclusive control of the risk assessment process and repeatedly and inappropriately classified women as low risk and therefore able to be cared for by midwives alone without the intervention or observation of obstetricians. So that professional boundaries and hierarchies play a role in securing or threatening patient safety is not news. But what's interesting, I think, about the situation at Furness General Hospital was how professional ideology of midwifery played into these politics. So it says that, this is a quote from the report, we heard distressing accounts of middle grade obstetricians being strongly discouraged from intervening. So it was the consultants were content to just be called, but the middle grade obstetricians, the regs that kind of circulate round, they were less happy about that, and that this resulted in quite kind of direct conflict between the midwives and the middle grade obstetricians. So this is from the panel, the Kirkuk report. We heard that some midwives would keep other people away. We don't need to tell the doctors, we don't need to tell our colleagues, we don't need to tell anyone else that this woman's in the unit because she's normal. And over time, these incorrect and damaging practices spread to other midwives, probably quite widely. The characterisation of normal from high risk births is at one time both a very routine part of midwifery practice, but also a deeply political practice. There's been concern for a long time about the rate of medical intervention into ostensibly low-risk births, and this is across midwifery and obstetrics alike. So, and there's still there's a Royal College of Midwives campaign for normal births, and this kind of testifies that it's still this site for political action. However, at Furness General, the zeal with which the women were categorised as normal and thus eligible for midwifery-led care came in for particular concern. And the midwives were characterised as being overzealous in their pursuit of the natural childbirth approach, and this led to inappropriate and unsafe care. But one thing with my science and technology studies hat on, I was interested in is whether culture was being conceptualised as primarily human thing, or whether, you know, they took into account material and geographical and other elements of culture. And indeed they did. So the report builds a picture of the unit as one strongly influenced by normal childbirth, but it also teases out how organisational structures and geographical location contributed to the problematic culture of the unit. So it goes into detail about how Furness General is an inaccessible town on the edge of, you know, quite a sort of deprived area. You know, there's some deprived areas and some more affluent rural communities, and that many of the non-medical staff were born and raised in the town, trained in the hospital, and have worked there ever since. Medical staff have proved hard to recruit, and there's been little opportunity for joint working or shared experience with other sites. All of this contributed to the isolation of the hospital, and in such settings, practice can drift away from the standards and procedures found elsewhere. And this drift involved a particularly dangerous combination of declining skills and knowledge, and a drive to achieve natural childbirth, whatever the cost, and a reckless approach to detecting risk and managing mothers and babies at higher risk. And so in this you can see they're obviously thinking about what was going on at Furness General in terms of Decker's drift into failure, which is very kind of common to find in human factors discourses. So, you know, you can see how that understanding of human factors is leading into explanations. But then, you know, and in this drift, you get a sense of the kind of cultural detachment that had distanced staff and practices from reference points, from standards and guidelines, and how practices happen elsewhere. I mean, this is just one example of it. There was they also talked in detail about how repeated reorganisations of the management structures spread managers ever more widely and thinly, and actually sort of severed relations between what goes on at the kind of trust level, board level, and what goes on the ground. So quite a detailed understanding of that, really. So that's a bit just to give you the flavour of the culture of the place. So a bit now about what's this doing to accountability, and this took me a while to kind of puzzle out, really, because, as I say, I didn't just find one thing. What I found was this kind of proliferation of forms of accountability. So I've tried to look at where they kind of continue old forms of accountability, and where there are new forms of accountability emerging. So when you get to the end of the report, in the final kind of hard-hitting chapter about what's to be done and who's accountable, it's clear that, you know, that chapter starts with this is a quote from the report: the prime responsibility for ensuring the safety of clinical services rests with the clinicians who provide them, and those associated with the unit failed to discharge this duty over a prolonged period of time. So up front, right at the start of this final chapter, is a very sort of conventional, individualised and decontextualised form of accountability. And this is one example of that. It says we were particularly concerned. So one particular midwife is kind of singled out for you know, as being quite pivotal in what happened there. So we were particularly concerned at the conflicts of interest surrounding the position of maternity risk manager, who was also a supervisor of midwives. We believed that she was part of the close-knit midwifery group of musketeers. this, I haven't said much about this Musketeers bit, but I don't know if that strikes a chord with anybody. This scandalised the press and sort of dominated press coverage on it, to the point at which when I picked up the Kirkup report to read it, I was quite surprised to find what went on with the obstetricians and the paediatricians. You know, I thought it was going to be primarily about the midwives, but it was much more evenly balanced. So we believe that she was part of this midwifery group of Musketeers, and as a former Royal College of Midwives union official, had continued to act in a staff representative role supporting midwives. She was central to deciding how and whether and how incidents would be investigated, which were often investigated by herself. So, you know, I didn't have time to talk about it in this presentation, but in the paper that I've written, you know, there's a section on how actually the way this midwife was kind of behaving was actually quite in keeping with a long tradition of professional self-regulation, in which it's quite, especially in medicine, I think it's been criticised as being quite protective of its members. And, you know, I think when you think about, if you were going to try and contextualise this, then you would be thinking about, actually she's been working in a very remote, isolated area in this atmosphere of you look after your staff, you know, and so there, you know, there's ways the way you could begin to understand why she was behaving in that way, but all of that disappears in the final analysis, and she's highlighted for the role that she played. But she's not alone, and this next one I think is particularly interesting. So before you read it, if you just let me tell you, this is about the clinical director of the obstetrics and gynecology unit, and he's a consultant obstetrician, and this is the only example I found in the whole of the report where the interviewers are quoted verbatim as well as the interviewees. And that sort of struck me. Why would they do that in this situation? So I'll let you read it now. So this is the interviewer asking the clinical director, "You're clinical director, yet you don't ask questions of your consultants. You don't ask questions of the head of midwifery, even though you're accountable for the quality of care in the unit. You push things up to the chief executive, and you don't follow up when things don't happen. I don't get what your professional role is as clinical director. Everything seems to flow through you. I don't understand what you do." And his response was, "Tell me, what do you expect more? If you have concerns, you express your concern to your superiors. What more can you do?" And I was just kind of struck by how hard they were pressing the clinical director to accept responsibility, and his kind of apathy in response to that. And he elsewhere around this, they say that he'd in the interview he'd been professing to be proud of what he'd done as clinical director and as a consultant obstetrician, and yet, and this is the kind of panel of experts speaking, we can find no evidence of decisive leadership. You know, so they were very scathing as to the role, the lack of leadership of this clinical director. And so when I was thinking about how that was contextualised, you know, I think it's clear that that the kind of the panel of investigators, where they felt culpability to lie, you know, and without explicitly telling you, you know, they were conveying it quite clearly in the way that this exchange was presented. And this is quite different to how the clinical director of paediatrics was treated. So again, if you just let me explain. So this is this relates to the clinical director of paediatrics, and he was based at the Royal Lancaster Infirmary, and he had really tried to change practice at Furness General Hospital. So he wanted to spend one day a week working with the consultants at Furness General and joining them on their ward rounds, getting involved in clinical practice there. And the the paediatricians at Furness responded to this very negatively. They felt it was bullying and intrusive, and they wrote letters of complaint to the chief exec, and this clinical director was investigated and sent on management training and instructed not to approach it that way. So he tried really hard to change practice, and he'd come across all these barriers and been quite, he'd been criticised quite severely for approaching it that way. And this all gets a lot of space in the report about how much this clinical director had tried to change things. And so this is the clinical director speaking, saying, "That's my feeling about child health in Cumbria, that actually the whole system is full of highly motivated people, really well-intentioned people who don't realise that their actions are having a negative effect in other places." And then the narrative of the Kirkuk report continues. "In relation to the clinical incidents, the clinical director felt that the midwives had become disproportionately the focus of attention, and that the paediatric team, himself included, was overlooked and bypassed. He also believed that the obstetricians were less in focus than they should have been." So, there's still kind of individuals being picked out, but it's a much more contextualised and in a sense collaborative way of form of accountability being enacted there. So in addition to that, there's also, right the way throughout the report, there's continual kind of noting of the way that nobody challenged, nobody raised awareness, nobody kind of saw it as their role to kind of address what was happening. So this is one example. It's evident that none of these manifestations of poor working relations are in the best interest of patients, but there is a lack of awareness among staff for their responsibility to help solve these problems. So they kept saying, that it was clear for all to see really how kind of dysfunctional these relationships were, but they just continued. Everybody was too complacent about it. And but the ease with which one might raise a challenge is not evenly distributed amongst all practitioners, and this is something that I think the authors of the Kirkuk report had an awareness of, and they focused in particular on the obstetricians. That the obstetricians working in the unit, they were well placed to observe these lapses from proper care, and it's clear that they did, but seemingly lacked the determination to challenge these practices. And actually, when I think about it, now it's only kind of becoming clear to me, but all of the kind of members of the panel were they all had leadership roles, clinical leadership roles, and in the Kirkuk report they were very hard on the leadership. I mean, perhaps rightly so, but people in leadership roles in the Furness General came in for particular criticism. And so, again, with my STS hat on, not looking at just the human element of it, but also the way that the non-human element can be addressed. I mean, this is a particularly sort of thorny issue. Over debates around non-human agency have been going on for quite some time in STS and beyond, and I think this has developed quite a sophisticated understanding of the way that agency is distributed amongst a collective, but still it's hard then to think, well, what does that mean for accountability? And non-humans can't be accountable in the same way because they don't act in the same way. So, and here in the Kirkuk report you get an attempt to address the non-human element as well. So here they say the Trust should review the skills, knowledge and competencies of professional duties of care of all obstetric, paediatric, midwifery and neonatal nursing staff, and other staff caring for critically ill patients in anaesthetics and intensive care, high dependency care, and review that against all relevant guidance from professional and regulatory bodies. So this is an attempt to reconnect with practice elsewhere and to reconnect with national standards of practice, and perhaps even necessitating a period of experience elsewhere. So they're trying to ameliorate the effect of a remote geographical location. And there is other examples as well about how the physical environment of the midwifery unit and the operating theatres needed upgrading and improving, particularly to allow for better observation of labouring women. So, conclusions then. So, I propose that inquiries, they don't replace professional regulation by professional bodies, but they do in some ways displace the authority that this is kind of traditionally carried, by augmenting the existing moral, legal and professional ways in which a practitioner's actions may be scrutinised and held to account. Inquiries are different to pre-existing forms of professional regulation or accountability in many ways, but it's particularly worth noting, I think, that they're not constrained to examine the actions of one particular healthcare profession. I don't think you'd have got as good a sense of the kind of dysfunctional working relations if you'd have looked at obstetricians separate to midwives, separate to paediatricians. So inquiries cut across professional boundaries, a factor which disposes them well to examine the connections between the connectedness of actions and the relations between actors. And although inquiries are structured in such a way as to lean towards conventional individual forms of accountability, current understandings of failure in patient safety, as well as the breadth of inquiry, allow for visibility of interprofessional relations and predispose the inquiry to look at organisational and collective factors. So in the end, all of these factors go some way to explaining the proliferation of forms of accountability enacted in the Kirkup report, and these place inquiries squarely at the heart of the individual collective tension in accountability. Thank you.
I'm just going to stop the recording because I think having the questions won't be helpful. But if somebody wants to put up their hand so I know they want to ask a question. Sorry. Peter.
I mean, your final point saying that it hasn't displaced sort of individual professional accountabilities and